Hello everyone. Today I wanted to discuss abruptio placenta, a common obstetric emergency that we have to be conversant managing. It's quite common because we have so many patients on the wards every day with hypertensive disorders in pregnancy, which usually would complicate to abruptio placenta. So the objectives of this presentation today is letting us know what abruptio placenta is. Secondly, how do we differentiate it from other causes of antepartum hemorrhage, and finally, how do we manage this condition. And so, as usual, we start from our terminology. So, placenta abruptio is called by several names. It's abruption placenta, abruptio placenta, and some call it accidental hemorrhage. It's all the same thing. Placenta abruptio is really detachment from the uterine wall of a normally sited placenta before the delivery of the baby. So this is as opposed to placenta previa, which is bleeding from an abnormally sited placenta. Even if we have a detachment of the placenta in placenta previa, we wouldn't normally call that abruptio placenta because that placenta is not normally sited. So we only call abruptio placenta detachment in a placenta that is normally sited. These are the two common causes of antepartum hemorrhage that we have to differentiate clinically. Vasa previa is kind of a bit more obvious because it's usually associated with rupture of the membranes, and then there is fetal distress after rupture of the membranes because the fetal blood vessels are passing through the membranes, and once the membranes rupture, the fetal membranes tear together with the blood vessels and therefore cause fetal bleeding, and therefore we have fetal distress after rupture of membranes. That would be like a history that you get from a patient who has a vasa previa. The other bit about terminology that we have to be aware about is that we only say placenta previa or abruptio placenta in our setting when we go beyond the age of fetal viability. So when we are below 24 weeks, we would normally be saying this is a threatened abortion, really regardless of how the placenta is detached or where the placenta is implanted. We'll just say this is a threatened abortion and we'll manage it as such. So placenta abruptio is classified in different ways. The ones that I think of note is one where you classify it as severe and non-severe. So severe abruptio is a kind of abruptio where you have maternal or fetal compromise. So when you have a fetal death, you'd call the placenta previa or the placenta abruptio as severe abruptio. And in cases where you have shock in the mother, disseminated intravascular coagulation in the mother, and you have a mother that ends up with a hysterectomy as a result of abruptio placenta, that would be called a severe abruptio placenta. Then we have what is called partial abruptio and complete abruptio. Partial abruptio means that only part of the placenta is detached from the deciduum basalis, or we have complete abruptio when the whole of the placenta is detached. We have to note that sometimes you can have a partial abruptio with a lot of bleeding and a complete abruptio where you have a baby that is alive. That is possible. So we shouldn't say that when we have a partial abruptio, then we have less bleeding because sometimes that's not the case. So of course, it's common sense kind of to think that when you have a complete, then there'll be obviously more bleeding. Then the last type of classification we have is what is called a concealed abruptio and a revealed abruptio. So we have a concealed abruptio when we have abruptio placenta, but we have no vaginal bleeding. So the placenta has not detached at its ends, so the blood doesn't seep through the membranes and the uterine wall to come through the vagina. In the case of a revealed abruptio, blood seeps through from the placenta in between the membranes and the uterine wall and is then seen coming out of the vaginal opening. So that's the difference between a concealed abruptio and a revealed abruptio. The clinical point on this is that we have a very difficult diagnosis if we have a concealed abruptio, and usually the diagnosis for abruptio is much easier when the bleeding is revealed. So what are the risk factors of placenta abruptio? So sometimes we don't have any non-risk factors and we just find that the patient has an abruptio placenta, but there are some obvious things that would obviously cause abruptio placenta. This could be trauma. The common thing in our setup is hypertensive disorders that include preeclampsia, eclampsia, and chronic hypertension. In preeclampsia, this might be because there's a failure of proper trophoblastic invasion, so the uterus easily, or is it the placenta easily detached from the wall of the uterus. There are other things like drug abuse, cocaine, smoking, the age of the woman, multiparity. Even rupture of membranes is a risk factor for abruptio placenta, because with a sudden decompression of the uterine cavity, the placenta can detach. A placenta implanting on a fibroid is also another risk factor for abruptio placenta, maybe because the placenta does not completely embed itself in the uterine wall. So placenta abruptio patients usually present with pervaginal bleeding, and this is the commonest presentation. 80% of patients come with pervaginal bleeding, but we have to be aware and just remember that sometimes they don't bleed because they might have concealed hemorrhage. The blood is trapped behind the placenta, and therefore there's no bleeding that we are able to see. The books also talk about the blood being dark as opposed to bright red, what we find in previa. But really the important part is that there is bleeding in a lot of placenta abruptio patients. The next common presentation is abdominal pain associated with this bleeding. So abdominal pain, contractions, is really back pain, is something that is very common with placenta abruptio. About 70% of patients have this complaint of abdominal pain. But again, we have to remember that some patients might present with no abdominal pain, especially those who have like a posterior placenta might present with no abdominal pain. Then there's always some fetal compromise associated with placenta abruptio. I think that's about in 60% of the cases. So there's blood, there's a clot, retroplacental clot, and perfusion to the fetus is impaired. The fetal heart goes abnormal. The fetus is in fetal distress. So that is also a common presentation. We need to remember that after 28 weeks is really when we talk about placenta previa, as already discussed in our previous slides. Then the really sure way of differentiating placenta previa and placenta abruptio is usually a scan. A scan will tell us there's a low-lying placenta, and if somebody's bleeding, they have abdominal pain, there's fetal compromise, then we know for sure that very likely what we have is abruptio placenta. There's also a way if somebody's pouring and we don't have to do scan, we can take the patients, if we are in doubt of their diagnosis, to theater. We can do a vaginal exam in the so-called double setup, where one surgeon is doing a vaginal exam, the other is ready to do cesarean section in case there's pouring. So that's another way we can differentiate these two conditions in cases where we don't have scan, or in the cases where it's inappropriate to do a scan where a patient is bleeding. So once we have our diagnosis, we have vaginal bleeding after 28 weeks, we have abdominal pain, we have backache, we have fetal compromise. We make a diagnosis of abruptio placenta. What do we do? So these patients are bleeding, and we know that because of the fact that some bleeding might be concealed, sometimes the amount of bleeding is less than what is a bit more than what we can see. So we need to get our ABCs, make sure the air of the patient is okay, they are breathing okay. We look at their circulation. We start IV fluids. IV fluids are very important in abruptio placenta patients because they end up with renal failure. Because of this hypoperfusion to the kidneys, they have acute tubular necrosis, cortical necrosis also is common. So we need to make sure we perfuse the kidneys. We give them as much fluid as possible, monitor vitals so that they don't go hypovolemic, because renal failure is quite common in patients with abruptio placenta. So it's important to see that the kidneys are properly perfused. Then we do our investigation, a full blood count, urea and creatinine, LFTs. These might act as baselines, and they might also indicate they're already compromised organs. The other thing is that these patients might also have normal vitals, but we should not be deceived. They have normal vitals because most of our abruptio placenta patients are a result of hypertensive disorders in pregnancy. So they might have bled, but their vitals look like in the normal range. So this is something to be aware about, and it might be a cause of delay in treatment. And we also know that the physiological changes of pregnancy also increase on the volume. So before you get to a point of a fetal death, secondary to abruptio, most of these patients have bled half their blood volume. So it's important to realize that there's a lot of blood loss despite what we can see. Then we need to do our bedside clotting time or coagulation profile. Many times we don't have coagulation profile. Our labs are not able to do, so we normally just do a bedside clotting time. Anything above 7 is abnormal. Anything below 7 is okay. So so we have to do our bedside clotting time because abruptio placenta is associated with disseminated intravascular coagulation, and therefore it's important to do this. So when the placenta detaches, all these placental thromboplastins go into the circulation and then cause disseminated intravascular coagulation, which eventually leads to lack of clotting of the blood, which eventually leads to hemorrhage. So doing our bedside clotting time would be important. We need to make sure IV fluids are available. As already said, we need to make sure we get blood, fresh frozen plasma, as much blood as we can get, because these patients more often than not have a coagulopathy. They have coagulopathies of different degrees. So it's important to make sure that blood is available. Immediately we make that diagnosis, and then we get that blood. We need to catheterize the patients for reasons already said. Make sure we measure the urine output because of the increased risk of renal dysfunction in these particular patients. So in these patients of abruptio placenta, we would usually aim for vaginal delivery. We don't want to do a cesarean section. We want these patients to deliver vaginally because they have a coagulopathy. If you go and cut, you cut through the abdominal wall, they'll be bleeding. You cut through the uterus, they'll be bleeding. Everywhere you put a stitch, they'll be bleeding. So you want these patients to deliver vaginally. But sometimes we are pushed against the wall. We have placenta abruptio when the fetus is still alive. That is a common indication for cesarean section. So you have a situation where the fetus is still alive and there's abruptio placenta. That clot in the retroplacental space continues to expand, and if nothing is done, that fetus will die. So this would be one of those indications for cesarean section. The other thing in our attempt to go for vaginal delivery is when you have labor that is really progressed. You are not very far from vaginal delivery. Maybe the patient is already fully dilated. Maybe they're about 8 centimeters or so. The fetus, the fetal heart is okay. Maybe in that situation, there's a room to get patients to be delivered vaginally. When we look at a diagnosis of placenta abruptio, in our setup, again, we are already beyond 28 weeks, and we've made this diagnosis, so we are not really looking at the gestation age. Once we make this diagnosis and the patient is bleeding, we don't look at the gestation age. We just deliver once we make a diagnosis of abruptio placenta. The other thing to note in labor is that early rupture of membranes is important because it decompresses the uterus and prevents or reduces the amount of tissue thromboplastins going into the circulation, reducing the effect of placental thromboplastins on the coagulopathy that we already have. So it's important to rupture membranes early. Rupturing of membranes early also helps to make the patient deliver as quickly as possible. The role of oxytocin is a bit controversial. We need to remember that we need to individualize the use of oxytocin in a patient with abruptio placenta because once the oxytocin is given, the uterus will contract, and sometimes these patients already have a high pressure. Their uterus is already irritable and it's contracting. So if the contractions are good, let's not routinely give oxytocin. Let's assess the contractions, and if we see that they help in the delivery of this patient, then we can give oxytocin, other than just giving oxytocin to somebody who's hypercontracting, as is usually the case in patients with abruptio. Their uterus is irritable and it's contracting, so it's good to do an assessment and see if the patient needs oxytocin or not. So for a cesarean section, if it really needs to be done, like in the case of a live fetus, like in the case of somebody who's pouring and they are remote from delivery, it's important that cesarean section is quickly ordered and done, and we make sure that we have the most experienced surgeon doing that procedure, because that patient might need a hysterectomy and they might bleed a lot, so we need all the blood products available and have somebody who can do a lot of hemorrhage arresting procedures present before the procedure is done. It's important to remember that if we have a patient with a coagulopathy and the baby is dead, it's important that the coagulopathy is corrected. So we get blood, we transfuse blood. When the fetus is dead, we have to prioritize that all the maternal parameters are optimized. The mother is properly resuscitated, her coagulopathy is corrected before we induce labor or before we take the patient for cesarean section, depending on the clinical situation. So that is very important to remember, not to compromise the mother not to be in a hurry to deliver when the mother is compromised and the baby is already dead. So we optimize the mother before we deliver. It's important to give oxytocin at the end after the mother delivers, because we know that contraction of the uterus is the major thing that will stop the bleeding. A mother with a tonic uterus will die quicker than a mother with a coagulopathy if we don't have that uterus well contracted. So once the uterus is well contracted, a mother with a coagulopathy is going to very likely survive. Then lastly, when you do your C-section, you might find a black uterus, what is called a COUVELLAIRE uterus. So blood has perfused the uterine muscle and it has colored it blue. Sometimes it goes up to the tubes and even up to the ovaries. Sometimes blood even finds itself in the peritoneal cavity, perfusing through the uterine muscle. So this is not an indication for hysterectomy. It's just telling us that the uterus might not contract well, and we have to be aggressive with our uterotonic agents after delivery. So then we need to take this patient to a high dependence unit or an ICU for monitoring of vitals after delivery, continuing to transfuse, continue to correct all the abdominal parameters until they are stabilized, and they can be taken to the postnatal ward. So that is how we generally would handle abruptio placenta. Thank you so much for listening, and we'll see you next time.